Well, hello, everyone.
Hello.
Okay, as of course,
Shabbat Shalom.
exactly. But as of course, I had to do some soul searching. So I called it grounding, but we'll get to my definition of what grounding is. Because the goal is really to get everyone to think outside of the box for most intensive purposes, to understand that what our definition of what we call vision is not the standard definition, because we include the hierarchy from our forefathers, from the four circle integration. Bear with me, there's a reason why I called it flat. To consider the other issues present when working with various conditions, and to also consider the brain and mind black box. Our treatment goals are really, what are they? I'm hoping you don't agree with number one. It's not just to normalize the analytical findings that you have. It's not only to decrease their symptomology. It's not only mechanistically getting you to align people's lives. It's actually intended for you not only to achieve clear single binocularity, but more so to help the patient function in everyday activities. And to achieve what we call optimal stereopsis, or to rehabilitate for the functioning visual system. The reason why I called it grounding is because we want to think integration. We want to think there is a consistent integration of all our abilities. Constantly, we have that biofeedback loop. We constantly keep looking at that within the body. Now, the importance is not what is in the four circles or how well they function, but more so the overlap. The integration and the looping back also incorporates the black box, close to what Greg was getting at within the stimulus and the response. That's again within the body when it corrects itself. The looping that I'm talking about, we all recognize this, okay? We all recognize that the emergent between the anti-gravity, the centering, identification, and speech and auditory is vision, which is that little area in the middle. However, the reason why I talked about this, and I will get to it, and we all know anti-gravity, it's actually primary. The primary before it goes out into the world. This is who am I? This is where am I? I like to refer this as the new. Of course, me being Greek, I always use Greek terms. Okay, the new is the gestalt of you. So it begins here, and then it goes out. Since it deals with personal existence, it deals with the primary position of vision. And this needs a fully functioning working system. Centering, this is where is it? Location, okay. Where it is from primary position, okay. This tells you how the new pulls things out into the environment. Identification, this is who is it? This is what is it? This has to do with your experiences. This has to do again with the new being worked to used from your experiences to recognize what is out there and what am I dealing with. It incorporates knowledge, it incorporates your existence, it incorporates everything you've done up until that point. And the speech and auditory is, again, the senses being used so we can understand what is it like. Okay, we use this, and this is the first, what I call biofeedback loop in the system. However, I want to extend this. And of course, We will get to that in a second. I just wanted to touch on a few things that we talk about, depending on what you deal with. In rehabilitation, or what we call vision therapy techniques and procedures that are used to help the system. It's an attempt to help an ailing system. It's you, depending on where the ailment is. So this is for people, or my students that we used to do this years ago. We used to break it down for them and say, okay, if they have issues with anti-gravity, do a little bit of balance board, try to bring it back. If you have difficulty in identification, heart chart were great. Okay, if you had difficulty in centering, we tried to use the Brock string. That was my favorite.
Yeah.
Okay, and then again with speech and auditory, we used tachistoscopic work. Okay. But what if we change what we knew? What if we change this and give it an extra spin? What do I mean? I mean, it's not just the lines in between. I mean, it should be more like that, with the base being the 4 circles and everything going up the hierarchy to actually make vision on top. Because imagine how these circles intertwine during integration. They're intertwining and they're creating something that should be at the peak, which is vision. So if you don't mind, let's start with this. We start basically with oculomotor control, total mechanistic, total basic work. And then we work our way all the way up through attention, through scanning, through pattern recognition, through visual memory, through visual perception, all the way up to the adaptation through vision. So let's begin then with motor. And in a child, if I may, depending on how many children you work with, this is how I would explain it to my students. Most things start with motor. Then they go into motor visual, then visual motor, then hopefully to purely visual. This you see when a baby sticks their fingers in their mouth to get their motor. Then sometimes they actually, after that, they'll start to look at their fingers. And then when they look at their fingers first, and then they stick them in their mouth. Okay, versus if they just look. You have to understand there's a hierarchy and a higher level in integrational skills, and I think most of us know that. The concept of integration is important within the body's own feedback loop. So this is again why I was talking about this, because I think the integrational skills are the most important for us to allow for the optimal level of vision to be produced. Okay, the new, or the gestalt, or the psyche of the individual actually governs all these integrational skills. Why? What do I mean by that? I mean the integrational skills go step by step, all the way up to the visual pathway, depending on experiences, knowledge, how you navigate the world, and how is everything used. So then we can consider various ways that the mind can govern the brain. If you're Piagetian, totally miss them. But if you're Piagetian, you'll understand what I mean. The actual mind will take over the brain and make you see it in a different way. What do I mean? I mean, you don't actually look at the bug while you're driving. Physiological diplopia awareness is one of the basic integrational skills we learn. We learn to ignore that there's one bug there, even though we're actually seeing 2, if you don't mind me using that term. There's most people, 2 eyes, you see 2 bugs if you're staring straight ahead. Unless you're staring at the bug, then you'll only see 1. So this is actually a great sign of how the mind takes over and tells the brain what to ignore. I like the term that was brought up before about splinter skills. This is one of those concepts, but this is done without consciously being aware. Some patients, though, don't have this, so then we have to go back, break it down and rebuild it. We see this all the time. And we're like, well, why aren't you seeing double all day? Because again, the splinter skill of suppression. Even though the brain receives information from both eyes, okay, this is a mechanical issue where the brain just shuts off. I mean, the mind shuts off what the brain is actually getting as input. So it creates a suppression tendency. And for stuff that I also deal with many times, some of these suppressional tendencies we even have with visual neglect, with any kind of head traumas. You see patients come in, they only did makeup on half of their face. Or when you ask them to reproduce a clock, they'll draw it where they see all the numbers from 1 to 12, but they'll only draw it on one side of the actual clock. So that means they're actually seeing it, but the way they're actually seeing it here, I'm sorry, the Greek term of seeing is so much better. The way their view up here is, okay?
It's the Greek term.
Το βλέπω, αλλά το εστιάζω διαφορετικά. Excuse me, I see it, but I'm understanding it or viewing it differently. And that difference is visual neglect. Because even though the visual field tests to be intact, this is what happens. So this again is another skill that's unconsciously made from the mind to take over what the brain is actually showing as input. This is another one. I love using box strings. I've been phenomenal about stringing them in different levels in different areas of a room. And whenever you see this, it's great. Because when you tell patients, okay, look at it, and like, oh, you finally see physiological diplopia awareness on this, and you can actually build them on that. But my favorite is when you see this patient is mechanistically not aligned, and they're only seeing one string coming straight out. That's their mind's eye. Because the mind takes over the input from the brain because it's contradictory to the visual input. And you see one string. So these integrational corrections are the mind over body. Physiological diplopia awareness, ocular suppression, visual neglect, or harmonious ARC, which is totally, I think that's a horrible term, but because it's not retinal. Okay. Or even unharmonious, where they see two strings. Okay. That again is the mind's eye taking over. So we can go over this and explain the other cases that you may see with various eye issues, which are basic splinter skills that actually patients have learned to live with. I'm glad Steve brought up that case because that sounded like patient B to me. Okay, but we'll get into that. Case A was prism adaptation. I remember years ago being at SUNY with Izzy Greenbaum. Okay, we were actually working up a strabismic patient, 20 diopter turn, just 20 diopter mechanistic turn. We had
Greenwald.
sorry.
You
Yes.
said greenbound.
I'm so sorry.
Greenwald.
Greenwald. Oh my God, I'm so sorry. I'm thinking about two different people at the same time. Izzy Greenwald, yes, Marty Birnbaum and Izzy Greenwald. They were in the Strab department, yes.
It just hit me, sorry.
Thank you, I'm
Go.
sorry. It's okay. Prism, 20 prism diopter turn. This patient, we had to pull out Fresnel prisms and we stuck on about 145 prism diopters. And they still ate it up. So that prism adaptation test, and we had a strabismologist sitting in the room and he goes, what do you do then? I'm like, you don't do surgery on that one, that's for sure. This is a splinter skill that the mind took over what the brain input is and just kept eating it up, and the turns kept staying. Case B, I love my synoptophore. I have 2 of them in the office. I love using them. But when you see exactly what Steve's patient was described, where they come closer to start to fuse and one jumps up. Everybody's seen that, or they disappear to the other side. Parafusionalis. This is again, the mind taking over to get the shortest distance to be less painful for the patient. Patients like this, you treat very carefully. Okay, you work on the surrounding and you slowly come back in. Because these are usually small angle deviations, but they have enough built up skills, which are amazing. My grounding case was fun. This was actually a child that was totally distraught, would only sleep with his head on the mattress by his mother, and his feet had to be on the floor. The minute they put their feet up, couldn't sleep. This child needed to sleep that way, and he could not function otherwise. And this affected the child's perception of the world and his integrational skills. So many of the times, what we did is we went on the floor and we started checking all the primitive reflexes, and we found that this child needed a lot of help. So we started at ground 0 and we built him up. So why am I getting through all this? The eyes, depending on how you start. I started working for Jeffrey Cooper, total mechanistic doctor. My first day as a vision therapist, I saw a kid, just came out of strab surgery. We tried to get him to fuse a vectogram. Okay, it depends on where you start, and then you have to keep looking back and fix yourself, because that's the whole concept of life. The eyes motorically pick up images that are relayed from the gray matter of the brain. But this is the fun part. It gets corrected by the mind. This correction of the mind takes over what is inputted from the visual system, and the output is the corrected mind's view. That is my assumption. So again, back to Piaget, brain versus mind. To me, the mind is the black box. The input coming into the black box is filtered with our new. Our new includes knowledge, experience, psychological status, and gestalt of the whole system. In other words, if I have heart palpitations, if I'm breathing heavy, if I'm scrunched over, if I'm relaxed, if I'm stressed, all that changes it. So the output varies amongst us all, but also within each other. And the hierarchy of vision, I felt, should not just be 4 flat circles. I know this is blasphemy. Bear with me. Think of it as it was a great, great concept, because those 4 lines really are all the integrational skills of the body. But to me, it should be almost extended up towards the middle, so that way vision can be obviously seen as the top of a pyramid that includes the nu, includes your mind's eye, includes the black box. And it also is dependent on experience, knowledge, and psychological status. So if I may, that should be that, in my opinion. Vision, not only anti-gravity centering identification and your senses, along with the integration to reach the apex of the pyramid of vision. The reason why I did this is really, many of us have things happen to us, and over time, we start to rethink about what we're doing. Did I do enough? Did I not do enough? Well, what is my definition? Vision should truly be in our own mind's eye. Each one of us has a slightly different definition. But I'm hoping that everyone in this room, it's closer than everyone out of this room. Thank you very much.
All right, are there questions for clarification? Do you have a specifically,
I have a question for the breakout room.
we need that?
Yes, I will give that to you, but I
Please.
just wanted to make sure there's no,
Yes, any
Clarifications.
clarifications? I myself, it went a little quickly and I had to look up new,
yes.
and there was a little more background to it. Maybe it was in the first few slides, but it went too fast for me.
I've
Did-
spoken about it a couple of years ago too, and I'm sorry, I didn't want to hark back. But
Yeah, that's okay. Maybe I'll just ask, are you comfortable with and understand what because I had originally had some French training, and that means something different in
Yes.
French.
yes, it
Okay.
does.
I know. I'm just telling you what I needed more information on new. If anybody else would like, I'd like to hear you maybe give, like, we had Greg do the elevator speech.
Yes,
If
yes.
you could give us the elevator speech of what new is.
New is the philosophical and psychological being of everyone. Of your own individual being, if you don't mind.
It goes back to Aristotle.
Yes,
Based on what I just looked
right.
at. Yeah.
That's what Aristotle had said, that most people know the saying, I know now that I know nothing. But he actually said, my new knows that I don't, that my new doesn't recognize that I know everything. Okay. My question for the breakout team was, what are the integrational techniques in your own therapy program?
Oh. Why, say that again, please.
What are the integrational techniques that you use in your own therapy program? Because I know I love to overload a system. So you'll see me with rock strength sometimes, and I'll just overload the system, or with a lifesaver card, make you walk a tightrope forward and backwards while you're doing 2 cards. But again, I want to know what you do. Okay, I hope that was thought-provoking.